When I go down the preventive care route, I think it's fundamentally about education. And I think it's empowering people by giving them the knowledge and the tools they need for how to live healthier lives. But then there are so many structural elements also that come into it. Access to healthy food that differs dramatically from zip code to zip code. Even access to education, fundamentally, quality education that differs basically based on where you're born. And so I do think there's a whole host of things that we need to think about solving as a society to ensure that those preventive elements are in place so that we don't need to be sick care focused anymore, while at the same time making sure that people have access to the sick care that they need when they need it.
This is the Visible Voices podcast. I'm your host, Dr. Resa E. Lewis. In today's episode, I'll be speaking with catalytic changemaker, storyteller, Dr. Pooja Kumar. Now, Pooja grew up around the world. She did attend high school in New Jersey and then completed training at Duke, Harvard, and the University of Oxford. She's worked with the UN High Commissioner for Refugees, Save the Children, UNICEF, the IRC, that's the International Rescue Committee, and Médecins Sans Frontières, Doctors Without Borders. She's a senior partner and leader in McKinsey's healthcare public sector and social sector practices. She's also a global leader for the McKinsey Health Institute. Now, when we get to the conversation, Pooja and I are talking about how perhaps, her parents influenced and modeled how she would ultimately follow and lead her own professional journey. We're going to start by speaking a bit about you, the visible voice that you are, and then going into the work that you do with McKinsey and the McKinsey Health Institute. You were born in India. You grew up in many places, including Singapore, Jakarta, Toronto, New Jersey, which is where you landed for high school. Your parents both had very interesting jobs, and I'd like to start by asking you to share with the audience what your parents did and how you think those threads came together to make Pooja Kumar.
What a great question. So my parents did have interesting jobs and they had interesting lives. And I think their decisions to move us as a family so many places really did have a huge impact on my brother and I. I'm sure at the time I complained and didn't like it, but looking back on it, it was the most valuable thing they could have done for us in many ways. My dad worked in marketing across a range of companies, but also with pharmaceutical companies. And then after that, did a range of things in global health. And my mother worked in market research. And they also both worked their whole lives. So every move was interesting to watch how they would trade off with jobs and tasks with us and learning how to raise kids also in totally different countries and cultural contexts. I think their decisions shaped my brother and I in some similar ways and maybe in some different ways. First, it taught me about how flexibility is something really important in a mindset. And I still remember when my family moved from Indonesia to Toronto, Canada. It's a completely different lifestyle, right? In terms of the type of place you live in, the food you eat, the way you are taught to be independent as a kid, much younger. And it was a real adaptation for me, but much easier for me as a kid than, my parents, which in retrospect, I now see and I didn't see at the time. And so understanding and now viewing how they were really flexible to the cultures they lived in is one thing that really stands out. The second, I think, is just an appreciation for the world at large. It's pretty incredible now as I have young kids to think about how they just said, yes, let's get on a plane and move halfway across the world and did it multiple times. And I think it stemmed from the fact that they are curious people who really appreciate other people and other cultures. And it's something I have also learned to appreciate because of what they instilled in me. And then finally, hard work. We joke a lot about that being an Indian thing, right? But it's also a family thing. And it's something that I remember my grandparents also really insisting on. And I think it's something that has stood me in good stead.
You mentioned marketing for both of them. And what role currently with McKinsey is marketing?
Great question. I have never thought about my job in that way. And in fact, when I was a child, I remember being completely confused about what marketing really was. And it took me a while to kind of understand it. But fundamentally, marketing and market research, right? It's about understanding how people think, what they want, and then shaping what you are selling towards what they want. And right now at McKinsey, I think it comes out in terms of how my clients actually respond to their, in my case, mostly patients, because I work a lot with hospital systems, or their consumers. So for me, I grew up a lot with that language around me. I actually think in healthcare, we don't use that language very much. And a lot of it is still centered around providers ourselves or institutions ourselves versus patients. And so I think it's bringing a bit of that flavor to what I do in my day-to-day job.
You too are a reader. And in fact, one of the impactful books that you may or may not have on your bookshelf is by Philip Gurevich, and it's entitled, for the audience, "We Wish to Inform You That Tomorrow We Will Be Killed with Our Families." And it's about the Rwandan genocide. Go.
So I was first exposed to this book when I was a sophomore, I believe, in college. It was a happenstance lecture that he was giving as part of his book tour now, I imagine, at Duke, where I was at the time. And I walked out of that talk that he gave, A, having purchased this book, which I still have, by the way, as you alluded to, on my bookshelf, and B, with a broken heart in many ways. I remember I'd heard about the genocide, we were reading about it at times, but the visceral stories that he told and the systemic failures of the international community to protect so many people in Rwanda, and the inability of the humanitarian response system to fully be able to handle that volume of human disaster were things that just really struck me. And college is a time when, you have a lot of impressionable people like me who really take these things to heart. And I was lucky, I think, to be in his lecture that day. It really shaped what I did for the next several years. I went from being an English major to switching to a self-designed major in health policy with a focus really on refugee health, which is what I wrote my thesis in, and thinking I was going to go down a career path of global health and, eventually working for an organization like Doctors Without Borders. And for several years, I pursued that as a career, including taking years off and summers to work abroad with the International Rescue Committee, with the UN High Commissioner for Refugees, and several other organizations in places like East Timor, the Congo-Zambia border, and Azerbaijan on the Azeri-Armenian border, to work with these populations and see firsthand, how can we make things better for folks, especially in terms of their basic needs, including healthcare. And then I went to medical school. And for me, I think the delivery of healthcare to vulnerable populations became more and more front and center in my mind as I kept having these experiences. I still get to do some of that these days in different capacities. But I think fundamentally, it just points to the power of a book and someone telling a powerful story and really drumming on that story to bring, attention to a cause and to start this thread of trying to change something that is not just a single small issue in front of them.
Yeah. And really at the end of the day, I think it's all about stories and storytelling. And we are all storytellers more than we realize. And in your case, it sounds like you understood the impact of stories. And I will say your decision after medical school to pursue emergency medicine for a minute, we as emergency physicians are witness to all the stories of every single person that comes through the door. Every person we sit with, we are witness to stories. And the reason I believe we are all storytellers is because we have to somehow collate it, package it, put it in a chart, and even share it in conversation to, for example, the consultant, the primary care physician, et cetera. So these are all skills in storytelling. And I know that in consulting and in working with clients and businesses, you have to tell a story. And I have here that you have written, I try to make the quality and value of care better for the individual patient by improving the system. So I actually don't see all these pieces as disparate. I actually think they tell a wonderful story of all of your chapters leading up to your role now. The McKinsey site says, Pooja, that you serve health systems on large-scale performance transformation. You also lead the McKinsey work in U.S. public health. Also, you are a global leader of the McKinsey Health Institute. So, question one, what is the difference between the work of McKinsey and the work of the McKinsey Health Institute?
Great question. So, McKinsey, we serve clients, a range of different types of clients across sectors, across geography, but fundamentally, we are a management consulting company that works with clients on their most pressing problems, whether those are strategic problems or operational problems or a whole other host of types of problems or questions that they have. The McKinsey Health Institute is a nonprofit generating arm of McKinsey that we set up about 2 years ago. And the goal of the McKinsey Health Institute is to work with folks in ways that we don't do through our traditional client service. And really that comes down to two things. The first is to create research that will change people's minds on what we can or should be doing to make better outcomes happen in healthcare. And the second is to set up catalytic partnerships to actually go make that change also. And I know sometimes those are consultancy words, right? Catalytic partnership, what is that? But fundamentally, it's a partnership where we are not the sole agent driving it. We may not even be the main agent. We're likely not going to be the main player there, but we want to be the catalyst. We want to be one part of a group of folks or group of organizations that comes together and says, how are we going to really make big change and not just talk about change?
When you described what McKinsey does, essentially you're an emergency physician. You don't know what's coming through the door. You don't know what the client is going to need or what your job is going to do. And I've seen and worked with some of my best friends are business consultants. There's this level of you work hard, you play hard. Sometimes the timeline becomes emergent. Sometimes it's urgent. Sometimes it's less urgent. But I've seen that sine wave of activity of work that actually really, really reminds me of emergency medicine. I love that the Institute is so new and young and where it's going in terms of partnering. I love the word catalytic. One of the interests that I hold because of ultrasound and the use of devices and the development of devices and providing ultrasound for better, safer patient care is healthcare design, keeping the end user at the center of the design process. And a lot of what I've read in terms of the work of the Institute is very healthcare design, be that the end user, clinicians, be it the patient, be it the healthcare system, be it the government with whom you're working. And one of the things that is repeated about the Institute is this concept of investment upfront, and dollars invested upfront can result in lives saved. And I'm wondering if you can go a little bit more granular with that.
Fundamentally, one of our taglines at MHI, as I call it, is that we want to not just add years to life, but we also want to add life to years. And if you look at the data of the past several decades, we've actually done a pretty good job on expanding life expectancy. The issue is that the percentage of time that we spend in poor health is basically the same. So we're adding a bunch of poor quality years to our average lifespan. Now, obviously, those numbers that I threw out are not equitably distributed globally, right? So there are some places where we have not seen as many of the life expectancy gains and that the percentages are also off. And that's an issue that we also have to tackle collectively, I think. If I come back to your question on investment, I think it's fundamentally that we have a lot of knowledge about what works. And when we look at the plurality of evidence, there's actually great evidence about a lot of the core drivers of both morbidity and mortality. So I think our thesis is we have a lot of knowledge, we have a lot of money going into this space, right? And what could be more important than health? If we take all those three things together, the challenge for us is how do we come together to really think about scaling interventions that we know will help people, that we know there's a path to do it, but there still are multiple things in our way of actually doing these things. You know, we can probably talk about countless examples here, Resa, right? Whether it's access to antihypertensives for populations where we know there are significant disease burden, whether it's better nutrition. There's a whole host of things. But how do we make those smart investments early? And how do we get all of the folks around the table who need to be around the table to actually make the decisions so that programs can be directed towards people who need them and actually reach scale? And we're not stuck in pilot-itis forever.
I like that word, pilot-itis. I also love this description, this concept of spending time spent in moderate to poor health, because I'll talk about me for a second. I try to be very healthy and people are like, oh, you want to live forever. I'm like, no. While I'm alive, I want to feel good. I want to feel healthy. I want to be healthy so I can do whatever I want to do. It's that quality, not quantity. And as you just shared, we're kind of getting there in terms of quantity of years, but how do we value the quality of those years? And I think that's sort of spot on where to go. And I'd love to go actually into a specific example. And one report that I read about is looking at addressing the women's health gap. Can you tell the audience more about that?
Yeah. So we recently did a major research effort in partnership with the World Economic Forum that we presented at Davos last year, where we looked at really what is the difference in the health span, right, of women versus men, and what is the opportunity at stake if we actually were to think about reducing that gap. As we all know, women live longer than men on average, but they actually live, I think, about a quarter of that lifespan in poorer health than men. So we have a huge opportunity here, not just to more equitably treat diseases that impact women solely or disproportionately, but also to just treat and get on top of diseases that impact both genders, but fundamentally are undertreated or underdiagnosed in women. And the economic opportunity of unlocking those well years is massive for the economy.
Yeah. People talk about the US healthcare system as a sick care system rather than a healthcare system. There's not this value on prevention. There's not this value on empowering the patient. And again, human-centered design, bringing the patient or the caregivers to the table. You've had the opportunity to work in healthcare systems and in public health nationally, but also internationally. And I'm wondering if you have just one take-home point of something you would do to try to help the US healthcare system.
I would say that it's ensuring that people can get into the right site of care when they need the care that they need. Now, as you alluded to, that is a sick care statement. And so it's probably more to be likely to be said by someone who trained in emergency medicine than someone who didn't. And I should have probably said more around preventive care. When I go down the preventive care route, I think it's fundamentally about education. And I think it's empowering people by giving them the knowledge and the tools they need for how to live healthier lives. But then there are so many structural elements also that come into it. Access to healthy food that differs dramatically from zip code to zip code. Even access to education, fundamentally, quality education that differs basically based on where you're born. And so I do think there's a whole host of things that we need to think about solving as a society to ensure that those preventive elements are in place so that we don't need to be sick care focused anymore, while at the same time making sure that people have access to the sick care that they need when they need it.
Yeah. So much of what you just shared reminds me of the way the US healthcare system was built. It's very vertical, it's very hierarchical. And I think our delay in bringing the patient front and center, in educating the patient and having them have their own voice in their care. Susanna Fox came on and talked about her book, Rebel Health, how patients sort of created their own health revolutions when it wasn't being solved by doctors or by Western medicine. And even being able to check your own home glucose, that revolution came on because patients and caregivers were like, we're done. What do you mean we can't embrace this and do this ourselves? So I think you're right. And it's a complete restructuring of the way our system was built. And it takes money, investment. I've done some work with healthcare design with the built environment hospitals, and they've shown it over and over again. It doesn't need to be proven anymore. The more you invest upfront in the design, in the brainstorming, in the speaking to the end users, the more money you will save and the better ultimate design you will have. But that takes time, that takes patience, that takes money investment upfront, and people wonder, why does it cost so much upfront? Why are we investing so much money? But it's hard to see the long term or the long game.
It is. And, we are already investing a ton of money, whether we want to call it that or not. We are investing a ton of money. And, we're getting certainly some great outcomes out of it when you look at the US compared to other countries, but there's a lot that we're not getting. And I think it comes back to your point. What is it that a patient wants that would get them to the right care at the right time? What would make it easy? Not just what exists that they have to go seek out by themselves and fight through walls to get, but what would make it easy and natural? And how do we build that system?
You are a visible voice. And I ask my guests, when did they realize they had a voice? When did they start using that voice? So in your business consulting world, as a public health and healthcare leader, tell us about your voice.
Well, my kids, first of all, would disagree that I'm a visible voice, or please tell them that that's the case so that, it might improve my hit rate with getting the response that I want. I think it sometimes happens naturally at a place like McKinsey, where, like in emergency medicine, right, you're kind of thrust into the middle of working with people, working with institutions, and you do more and more of it, and it becomes natural. I think we're also lucky to have trained in medicine, where you realize the importance of an accurate, trusted voice very early in your medical training. You realize the importance of putting in the work so that when you come to that patient, you are doing right by them. And you alluded earlier to the way in which emergency medicine is actually very similar to management consulting. And I totally agree with you. I remember being shocked in my first few months at McKinsey of how structurally similar they both were. And that voice just comes over time. The exciting piece is when you can really make sure to match it with the content and topics that are meaningful to you, that tie to your past, because it makes it seem easy.
Your legacy.
I would hope to be viewed as someone who was a great sponsor. I want to say sponsor, not mentor. And I'm sure you and others have talked about this on your show. I would hope to be viewed as someone who pushed people beyond their comfort zones to do things that were sometimes difficult, make decisions that were sometimes difficult, but that were necessary to make their institutions better. And I would also hope to be viewed as a great mom who was maybe not around every dinner time, but when I was there fully.
Dr. Pooja Kumar, thank you so much for joining me on the Visible Voices podcast.
Thank you so much for having me, Resa.
The Resa wrap-up. Special thanks to Dr. Pooja Kumar for joining me in conversation. Now, audience, recently, the McKinsey Health Institute launched the Coalition for Mental Health Investment at the Clinton Global Initiative annual meeting. This has the bold vision that within a generation, investment in mental health will match the scale of global need. Their partners for this coalition include the African Venture Philanthropy Alliance, the Clinton Global Initiative, Kokoro, and Wellcome Trust. Now, what's the impetus for something like this? Audience, mental health is an issue that impacts the global population significantly, yet many struggle to find and access the support they need. There are clear societal and financial benefits to improving mental health, but it remains underfunded and underprioritized. That's all I have for you this week, audience. See you next time. The Visible Voices podcast amplifies voices in the healthcare, equity, and current trend spaces. We are a production of the People's Media Network. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Please find me through my website and on social media, Resa E. Lewis, MD, or through the podcast, thevisiblevoicespodcast.com. please give us a 5-star rating on Apple or wherever you listen to podcasts. Also, please be sure to share the show with a friend. The views and opinions expressed by the host and guests are their own and do not necessarily reflect the opinion of the institution with which they are affiliated or identified. Information herein should never be used as a substitute for clinical judgment or for medical advice.